Hi, and thank you for joining us for this session, which is Newly Diagnosed Ovarian Cancer One-on-One. I'd like to thank our sponsor, GSK, for making this session possible. In this session, you'll learn the basics of ovarian cancer and what to expect as you move from treatment through survivorship. Our speaker for this session is Dr. Nita Lee. Dr. Lee is a gynecologic oncologist at the University of Chicago Medicine who specializes in the diagnosis and treatment of women with gynecologic cancers. You can view her full bio in the downloadable conference program. Thank you for being here, Dr. Lee, and I'll turn it over to you.
Hi there. Thank you so much for the opportunity to be here today and to share with you my experience as a GYN oncologist, and thank you for the introduction. So today I'm going to be focusing on Ovarian Cancer 101, sort of a range or journey from diagnosis to survivorship, and this is something that I think is really important to think of the whole spectrum and the whole range and continuity of what happens after an ovarian cancer diagnosis. I'm hoping that we can, cover a lot of points, but at least give you a basic review of the basic biology, understanding of the biology, as well as a review of initial treatment options and the decision-making process. All of these treatment options really need to be personalized with you and your physician team, but it's really important to know what to ask for, know how to advocate for yourself. So when we think through these treatment options, we're going to also learn a lot of new terminology related to cancer genetics and tumor testing. Think about the idea of maintenance chemotherapy in the upfront setting, as well as the role of really thinking through what does survivorship mean. And I think another really important theme throughout this is how do we use supportive care and self-care through this process. I think that, one of the important things is that defining what cancer survivorship means for someone who's had a cancer diagnosis. So this terminology was created by a group of patients who had a diagnosis of cancer to describe the broad experience along the cancer continuum. So this means patients who may be living with cancer, living through a cancer diagnosis or beyond a cancer diagnosis, and really defines a cancer survivor as anyone who is diagnosed with cancer, who's undergoing treatment, who may have completed therapy, or is living with an ongoing cancer diagnosis, whether they're on active therapy, maintenance therapy, or on some type of break from treatment. There are many conflicting feelings about this in terms of feeling, patients of mine who've said, I don't really feel like I'm a survivor because I'm still on treatment, but I am surviving and I'm thriving. And that's really the important theme, that this is a sort of a personal choice and the diagnosis does not define you. So a lot of the things that we talk about, obviously we want you to relate them to your own experience, but I know that can be difficult sometimes. So this is a overview of a patient, and her daughter shared this with me. It's called La Forza. This is Kathleen Ritchie, whose family was Italian, and they said that when they were going through ovarian cancer and thinking through this, her father always said, "This is what this cancer requires," and so they really summarize this very nicely. And I often think about using this, and so this is a time of really focusing on things such as your inner strength, persistence, perseverance, resiliency, bravery, and courage. So this is a force that is called upon only in difficult times when facing incredible odds. And so I do love to share this because I think that anybody, whether it's a caregiver and patient who's facing ovarian cancer, are incredibly strong women that I've met, and I really appreciate how much I've learned. So looking at sort of ovarian cancer biology and basics, just to get everybody on the same page. Obviously, many of you will have already gotten through this and done your own research on this, or had family members or your own physicians tell you a lot about this, but just to make sure that you have this as a resource as well. So in general, ovarian cancer is not as common as other cancers in women. Obviously, we hear a lot about breast cancer because there are approximately 200,000 to close to 300,000 new cancers of breast cancer diagnosed in the United States annually. For ovarian cancer, we have about 22,000 cases, and we really have kind of kept at that number in general. In terms of the thing that is more serious and can be more concerning is that we do know that ovarian cancer can become more serious, and we do know that it is actually one of the top 5 cancers that women may die from. And so we do know that we have about 14,000 women a year who die from ovarian cancer, and our job is to try to make treatments and to make options even better to get that number to be lower. So ovarian cancer does have a pattern. If you think about where the pattern is, we know that in general, this happens on average with women in their 60s, but we do see cancers that can occur earlier. Sometimes women who have a predisposition to ovarian cancer due to hereditary conditions will see their cancers occurring earlier in their life, and we'll talk a little bit more about that later. The other issue is to know that there are also sort of a diversity of ovarian cancers, and so some of the younger cancers may be a different cell type than the more typical epithelial ovarian cancer. So in general, when you think about the incidence and the percent risk per person, you can see that on the left-hand column. If you have a first-degree relative of that, that may be that your risk may be as high as like 4 or 5%, but the general population, the lifetime risk is about 1 to 2%. One of the things that we think about are what are the types of ovarian cancer, and it's really important to understand that ovarian cancer is not one entity, it's actually multiple entities, and we're learning more and more about it. This is sort of a traditional schematic of how ovarian cancer and where these different cell types arise. So we can think about the surface of the ovary or the fallopian tubes or the inner lining of the fallopian tube giving rise to things that could be considered epithelial ovarian cancers, and those can be included in this table, which include different cell types within that, serous ovarian cancer being the most common, but also mucinous, endometrioid, clear cell. These are all different variations on epithelial ovarian cancer. We can also have germ cells, which arise from the cells that would normally support growing into a follicle or going into an egg. And then we can have tumors that arise from what's called sex cord or stromal or support tissue in the ovary. And these can also give rise to cancers. The grouping of ovarian cancer, you really have to think of it as a grouping that this applies to things that are diagnosed such as ovarian cancer, fallopian tube cancer, or primary peritoneal cancer, which is a cancer of the lining that covers this internal surface. So again, ovarian cancer, not one disease. So even amongst epithelial ovarian cancer, there is controversy as to like what is the cell of origin. We always used to traditionally think that it was always the surface epithelium or the surface lining of the ovary, which it could be. We can also see that the cancers can develop in the lining of the peritoneal cavity or in the fallopian tube itself. And so there is more data that we've learned from women who had risk-reducing surgeries. And when people studied their ovaries, we were also starting to see these precursor lesions that may give us a more understanding of the biology and also a better understanding of prevention. So this is really important to kind of think of as almost a field effect, and the idea that these cells may be arising in the fallopian tube and then going to the ovary. So there's a lot more complexity to this than just sort of saying it all arose from the outside of the ovary. Then again, we just have a lot of diversity. 80% of ovarian tumors are these epithelial ovarian cancers, and of those 80% are serous carcinomas. But again, the non-epithelial ovarian cancers are also really important. They do in general have an overall better outcome because those tumors tend to present in larger individual cysts, and they often present with symptoms when they're still in an earlier stage. When we think about these rarer ovarian tumor types, we know that there are different ways that sometimes they're treated, and there's different sort of molecular profiles or sort of what the patterns are, both in terms of how they present, the age groups, and also some degree of differences also in the treatment. So I think it's really important as understanding when you have a cancer diagnosis, like what is my cell type? Do I have a more typical epithelial ovarian cancer? Am I a younger patient who may have a germ cell tumor? This can be really important because sometimes when you go on the internet, you just see ovarian cancer and it's all a blur as to how to make that see whether it's related to you. So getting from your care team like which cell type and which type of ovarian cancer you have is very important. So again, like I said, their clinical presentation of these different cell types, the optimal regimen, the recurrence risk, as well as the response to therapy can really differ. This is really due to the fact that some of these cell types have different molecular mutations that cause that, and basically different pathways that are turned on and off that can promote cancer development. One thing to really think about is that how does ovarian cancer spread? And one of the things that we do think happens is that it starts at an original site, whether it's at the fallopian tube or the ovary, and it undergoes these specific changes that allows it to kind of leave where it started and kind of exist in the abdominal cavity. Once it exists in the abdominal cavity, it can kind of create these like clusters of cells that can then go and implant. And that's often why we think about ovarian cancer as being so difficult, because these cells often implant and have spread to other areas in the abdominal cavity before the tumor is very large or before anybody has any symptoms. So one of the really important things as researchers that we know is that we want our researchers to be able to focus on these different stepwise pathways to see if these steps can be better studied to find better sites for intervention. So can we intervene before it has the chance to spread? Can we detect it before it has spread? And so those are really important things to think about from the research perspective. So where exactly does ovarian cancer go? And then I do not understand as an audience, many of you may have experienced this yourself, and this can be a little bit distressing to discuss, but really a lot of ovarian cancer extends directly into the abdominal cavity. So you can see these little seeds that can be maybe as small as grains of rice, sometimes can be as large as gumdrops, or even sometimes be kind of connections of small tumors that appear to be large masses. And this is a pattern that's different from other solid tumors and is a little bit unique to the ovarian fallopian tube primary peritoneal spectrum. These cells that are shed can spread and land on those other areas, and they don't always invade directly, but they can always cause some injury or some of the bowel function not to work well because of where they're sitting. We can see ovarian cancer that's spread through the bloodstream. It's a little less common, but it's important to know that we can also see lesions that have spread to the lung, as well as lesions that have spread to the liver or other areas. We also look out for the lymph node areas to see if there's any spread there. So some of the basics in terms of some risk factors that we know about that may increase your risk and some that may be protective. Age, obviously we know as women age, we see ovarian cancer traditionally in older women. Family history is very important from both maternal and paternal about breast, ovarian, prostate cancers, other cancers that could be hereditary. Infertility. Personal cancer history, so women who have a personal history of breast cancer, we really need to make sure there isn't a hereditary condition that could predispose them to ovarian as well. Issues such as early menarche, which means that you went through your period much earlier, or late menopause, and that's sort of like the time spent with that type of exposure, as well as endometriosis can be an independent risk factor as well. Now, sometimes I have patients who say, well, I don't have any of those risk factors and I still got ovarian cancer. So of course, we have to take these with a grain of salt and know that these are sort of the general trends that we see in large studies, but individual people, we need to know what's happening at that level. Things that we know decrease the risk for ovarian cancer are birth control pills, or OCPs, oral contraceptive pills. This is true for patients who are BRCA mutation carriers or not. Pregnancies, a tubal ligation or hysterectomy, breastfeeding, and of course having a very more radical risk-reducing surgery of removing your tubes and ovaries for genetic purposes. So I want to go through a little bit about steps in diagnosis and treatment planning to give you sort of an overview. I think that this talk should be really used as a little bit of a guide, and perhaps even how you can kind of explain to other friends and family members or caregivers if they're interested as to like what's been happening if you've already experienced this as well. So, one of the things that's important to know and to recognize and really acknowledge for a lot of our patients and many of you as well is that ovarian cancer is not always a silent disease, and that many times patient-reported symptoms such as abdominal pain, pelvic pain, bloating or distension, early fullness, irregular bleeding, GI symptoms such as constipation or urinary symptoms have been reported in the months prior to a diagnosis. And so I think really, as advocates and as people who may educate others about their own experience, I think understanding that we really want women to take those symptoms if they're new and different. If this is kind of, constipation happens all the time, or you're always bloated after you eat something in particular, that may not be as applicable. But if these are new and different symptoms that have changed, then really advocating to get more diagnostics done, such as an exam and ultrasound, those kinds of things is very, very important. So initial workup for ovarian cancer, sometimes that's actually done by a primary care physician, a family medicine physician, or a gynecologist. And so one of the most important things if you're having those types of symptoms is for somebody to do a full physical exam. So that includes an abdominal exam, a skin exam, checking for lymph nodes, but really importantly also a pelvic and a rectal exam to see if there's something that anyone can feel in the pelvis. Oftentimes, we order an ultrasound to evaluate the ovaries and CAT scans, which can better evaluate the rest of the abdomen. PET-CT, there are some providers who use PET-CTs. There's some insurances that approve it and some that don't. I don't feel strongly that everybody has to have a PET-CT, but people often ask me, what's the difference? I do think that CT scans are a little bit better at telling details and kind of like really measurements. And PET-CTs can be sometimes helpful when something is indeterminate and we don't really know if it is a cancer spot or not. The other thing that women will often have, and many of you will recognize, is the tumor marker. So the CA125, which is the most commonly one tumor marker that we use, but there are a few other ones that are available, such as HE4, to see if those elevations will correspond to something such as a mass, and does that sway us one way or the other? Does it make me feel more reassured, or does it make me feel like a little bit more concerned? There are other tumor markers for the other ovarian cell types, and so that's really important to know if you do have a more rare cell type to ask, like, what is my tumor marker? Is that a marker for me? And for some women, it's not, and for some women, it's helpful to know what you started at, so as treatments are working and as you're followed in surveillance, you know what your marker is. There's pluses and minuses and pros and cons to testing that, but in the initial workup, it's a really important step. We often also check your electrolytes, your blood counts, your general health, other measures in preparation for potential treatment and diagnosis. So one thing that I forgot to put on here is that oftentimes women will at this time potentially need to have some type of surgery for diagnosis if it's not obvious, or if things are worrisome on a CAT scan, they may have to have a biopsy. So usually an initial workup will require some type of pathology documentation to just confirm that this is a cell type that started in the GYN organs, in particular the ovary or the fallopian tube. So in general, I think of the initial treatment paradigm always having a combination of surgery and chemotherapy. And I think this has really changed dramatically over the many years, quite honestly, and also has changed again in terms of like how we're managing patients in different COVID-19 environments in terms of how that changes as well. So one of the first decisions that we're making once we've sort of had a diagnosis of ovarian cancer made either by imaging and or biopsy or just clinical picture is, are we going to do upfront or primary surgery, which means surgery first, or are we going to start with chemotherapy and do what's called neoadjuvant chemotherapy? And you can see the acronym, the NACT acronym there. So a lot of my patients will say, well, I just want you to go in and take everything out. I've just been, very stressed about this. I want it gone. And I think the important thing to remember is that we also want that goal, but we have to try to figure out what the best sequence is for you to have like one really good surgery. And so that's why there are many conditions or times when starting with chemotherapy may be the safest and best route, because when you're prepared for surgery, your surgery may actually be more successful at being optimal. And so that's a really important thing that I think is a little hard to wrap your head around sometimes, but it's important that we want to personalize that for everybody's cancer experience and the details of what is, where we know that the cancer may be. So the goal for surgery, whether it's before or after chemotherapy, is for having what's called an optimal cytoreductive surgery or tumor debulking. So we really want to leave no visible disease whatsoever if we can. But we do know that sometimes we have to leave these tiny seeds, almost ideally less than 1 centimeter, if they're in areas that we cannot resect, or they're in areas such as the surface of the bowel and there's too many that we can't take off. Usually this is an open surgery, meaning an up and down incision with the removal of the uterus, tubes, and ovaries and any visible tumors. We do know that these surgeries, when we perform them, can be very aggressive and can be very different than when you think of a regular standard hysterectomy for prolapse or for fibroids, and that this sometimes is a very long surgery. These surgeries can be between 4 and 8 hours. They can sometimes involve bowel resections, liver resections, kind of stripping any areas of tumor off of the peritoneal surfaces. So these are all things that we sometimes will be able to predict for you, but may not be. We do know that it's really important to think about your team and your surgery team. So we know that high volume centers that treat a lot of ovarian cancers and treatments with a GYN oncologist are really important. And I think that's important to have that member of your GYN team, of your cancer team. So the other things that I will mention here, because sometimes they're discussed, is the role of anything that's more novel. A trial that was done in Europe came out showing some improvement in survival for patients who may have received something called HIPEC, which is heated intraperitoneal chemotherapy at the time of interval surgery. So these are patients who had chemotherapy, had their surgery, had chemotherapy heated at the time of their surgery, and then had other chemo regularly. This is not necessarily standard of care, but there are some centers that offer that, and it's worthy of a discussion in terms of like knowing the spectrum of options for you. And a lot of that has to do with where the tumor is located, your performance status, and how healthy you are, and also the risks of that, because it's a little bit of a riskier procedure. Intraperitoneal chemotherapy delivered after the surgery through a catheter is also something that some people will discuss, although that has kind of waxed and waned in terms of favor. It's important to kind of get your doctor's opinion about it. So initially, when we're talking about chemotherapy, and again, this could be before you start your surgery or after surgery or between, is usually a combination of 2 drugs, carboplatin and paclitaxel. This true drug combination can sometimes be delivered via the intraperitoneal chemotherapy approach as well. But again, like I said, I would say that there's less people who get intraperitoneal these days, although the initial data was very promising. So in general, we give a cycle or a grouping of this every 3 weeks. It tends to be about every 4 months and 6 cycles, whether it's split or not before and after the surgery. Many clinical trials that are offered to patients in this initial setting use the backbone of carboplatin and Taxol and then add other newer novel agents to that backbone to see if we can even improve the outcomes. So knowing that, before I back up there for a second, knowing that in terms of initial therapy, many women will have a very good response to the initial combination of surgery and chemotherapy. So about 75 to 80% of women will have a complete response. We don't see cancer on either a CAT scan, exam, their CA-125 is normal. And the challenge with that is that what happens next is that we have to go enter a phase of surveillance. And we do know that ovarian cancer has a high risk of recurrence. And so that's kind of the struggle that we always have in terms of we want to do, a very aggressive upfront treatment, but we can't always predict completely who's going to be somebody who has a very long time without any cancer or ever coming back, and who may be somebody who struggles with the cancer recurring sooner. So in general, I just wanted to put this up here in terms of clinical trials process, and that there are different types of phases of clinical trials. And so it's important to kind of just be familiar with the idea about it, and that when you do get diagnosed, or if you're dealing with either an initial diagnosis or even a recurrence, talking to your doctor about what are the options for phase 1 trials, which are new therapeutics. Those trials are designed for safety considerations. Phase 2 trials also are looking at how effective are these regimens, and phase 3 trials are generally studies that are larger groups of participants who are looking at sort of a standard of care versus the standard of care plus something novel in ovarian cancer. So it's just important to know the terminology. So one of the things with chemotherapy and surgery is that everyone is unique and not all women experience all of these issues. But obviously the things that I talk to most of my patients about are things such as nausea, appetite change. We hope that many women won't have vomiting or, significant changes in their appetite so that they're too dehydrated. But your team will give you, warning signs and things to look out for. Staying hydrated and focusing on your nutrition is important during that time period. You can experience fatigue, hair loss that's temporary, neuropathy, numbness and tingling related to the Taxol can be very debilitating. It is important to report. I've even had some patients who were a little worried about reporting their neuropathy because they were afraid of going down on their dose because things had been going so well. But I think just to reassure that we do have ways to manage this more actively and try to help the situation and to try to prevent any long-term issues. So pain, as well as this idea of can you feel this idea of a fog or chemo brain, it's called. So some degree of losing your concentration power. And so this is these are areas that can really affect people's quality of life. And so making sure you're open with your treatment team about if any of these things are happening to see what you can do. So one of the things in the initial treatment that has changed a lot and is actually very exciting is these advances, although there still are controversies in the role of something that's called maintenance chemotherapy. So this is newer data. And again, this has actually been studied well before too. For example, people used to study what if I gave people Taxol for an extra year, where there was some benefit, but then there was also a lot of the toxicity of extra Taxol. So what maintenance refers to is sort of this idea of adding either additional chemotherapy or other biologic agents after initial chemotherapy and continuing that for some specified time period to see if we can decrease the risk of recurrence and improve overall survival. So some of the terminology that you'll see is something called PARP inhibitors, which is a class of drugs that we'll talk about in a bit, which have been studied in multiple trials and populations in terms of within ovarian cancer and have a lot of new drugs that are available to discuss about maintenance. Bevacizumab, or better known as Avastin in some circles, that's also something that has been studied and FDA approved for maintenance. But again, we really need to fine tune and personalize, who should get these medications? What's the cost to ourselves and to our patients, the co-pays, the cost in terms of quality of life, as well as what are the side effect profiles and what are we risking by putting people on maintenance as well. So all of these things, and I will say it's also the philosophy of patients in terms of how you're feeling about the idea of continued treatment. So personalization based on some molecular data that we may have, as well as personal preferences, is really important. So I know there's going to be some other talks that are specifically looking at PARP inhibitors, but this is just kind of giving you the idea. The PARP is an enzyme that actually helps to repair DNA damage. And so when you're giving chemotherapy, there is DNA damage that's created. And in some ways, the PARP enzyme that normally functions will actually work to repair that DNA damage and allow that cancer cell to potentially survive. But if you add a PARP inhibitor, it interferes with one way, which is called double-stranded DNA repair. It interferes with that pathway, and the cell is no longer allowed to repair its DNA, and then the cell dies. So in general, I'm going to get into this a little bit further about how this applies, because these drugs were first discovered and put to use and understood better in patients who did have BRCA mutations, which is another set of proteins that is involved with DNA repair. This again really shows you, again, when you look at PARP inhibitors, you see that, if you have PARP and you get this single strand break, without PARP inhibitors here, you can actually create a double strand break as well. And now what you can do is a normal cell, which has the repair mechanisms in place, will be able to survive, but a BRCA mutated cell or another cell, due to different mechanisms of defect, cannot repair that, will then be unable to survive. And that's why we use these in combination. Bevacizumab or Avastin is another type of agent that's called a biologic agent. And so what it is and based on is the fact that tumors require these new blood vessel growths to maintain growth and spread, and angiogenesis is the growth and development of these vessels. Basically, we want to avoid that, and the mechanism for this is that there's a protein that tumors often secrete called VEGF that can actually promote these blood vessels to arrive and help feed the tumor. So the bevacizumab is a compound that binds to the VEGF and reduces the concentration of this VEGF so that there's less available VEGF to create these new blood supplies. That's kind of a basic overview. And so this is a drug that's been studied in both the recurrent setting and the upfront setting and does have FDA approval, but you really have to talk to your doctor about whether or not this makes sense for you. So one of the things to really think about during the treatment and perhaps after the treatment that can really address both sort of physical and psychosocial needs are what are these other practices in complementary and alternative medicine? Yoga, mindfulness. A lot of places have switched to online, both yoga and mindfulness. A lot of different support organizations and advocacy groups have a lot of online resources. The use of meditation, acupuncture, massage therapy. Those things are things that could be added to your sort of your treatment plan as a whole and not necessarily adversely affect your chemotherapy. If you're going to be taking any supplements, however, we do not advise that you do that unless they've been cleared by your doctor, because some of them can actually ironically make your chemotherapy work less. And so we want to be very careful with what you're on when you're taking an active drug. The other thing to think about is to think about nutrition and physical activity during treatment. It's actually ironic that the cancer-related fatigue, one of the things that's been shown to improve cancer-related to fatigue is mild to moderate exercise. So this type of physical activity may be actually beneficial for both your physical and emotional health, but you just have to know your limits, don't be discouraged, small steps. And really in these days, like getting outside while the weather is good is probably a very important way to feel safe and comfortable. Again, also understanding what your resources are locally. So asking for a nutritional consult, maybe a physical therapy consult. Of course, all of us are dealing with COVID-19. And so sometimes there is obviously a fear of like having extra visits or extra contact. But again, the amount of telehealth that we're doing and the amount of online resources and YouTube videos and things that we can really kind of bolster now, I think we should take advantage of that type of technology for sure. So one of the things that's really important when we're thinking about this trajectory is to build your care team. So thinking about the role of GYN oncology specialists. So these are, like myself, we've trained in obstetrics and gynecology, and then we've done an additional 4 years of that OB/GYN training and an additional 3 to 4 years in gynecologic oncology, really training in the spectrum of advanced surgery and chemotherapy. So as a fellowship director, my job is to take individuals who are full-fledged physicians and could go into practice as general OB/GYNs and give them the training to really be able to take care of women with these cancers. We do know that surgical management by GYN oncology demonstrates improved rates of optimal surgery and overall survival. So thinking about who's going to be part of your care team may be important. And again, I think thinking about that surgical support team. We also kind of have a focus on gyne-specific care. So I think our understanding of the disease process, expectations, and also I would say a great deal of optimism about how to take care of women with cancer and ovarian cancer is really important, because sometimes other people have not been as comfortable taking care of advanced cancer and really pushing for cure. So medical oncology specialists are often very important because most women may see a medical oncologist to do their chemotherapy, and then a GYN oncologist may be sort of a part of the team. And we will often work very closely. So if my patient lives very far away, I'll often work with that team to kind of design the best treatment plan. So things such as like transportation, finances, comfort with level of surroundings, those are all going to be a part of what your decisions are, but really thinking about this as like a partnership and how you're building your plan. So I have patients who live quite far and only see me for their initial consultation, surgery, and then perhaps like from time to time once a year, or keep me up to date via sending me notes, as to how they're doing. And then myself and their medical oncologist can be in contact in case we ever needed to think about other treatments. The other important thing to really know in your cancer center, whether it's a small cancer center, a large tertiary academic center, who should you know? You should know your chemotherapy nurses, physician assistants, and nurse practitioners, and other physician extenders are really important resources. The fellows can be resources. The social work teams are amazing in terms of thinking about resources, such as transportation, or social work resources such as like getting a wig, or any other types of needs that you may have. And other community resources and hospital-based resources, different things such as, Women to Women program with OCRAs, one that we run in our program and are very proud of, community cancer resource centers that are in every local community, Society for GYN Oncology, Foundation for Women's Cancer. So there's a lot of different there's a lot available. Cancer nutrition and physical therapy, and I think integrative therapies we talked about as well. So again, thinking about your caregiving team related to your family and friends, we know that social support matters, and this is a really important part of your care, and we have to help you build that. Now, many people will have some family and friends, and some people will not have as many close resources that they can utilize, and so talking to your treatment team about how to build that social support is really important. Who you can rely on for different needs and who you may need to say no to for a while is really important. So establishing boundaries, as well as a balance of privacy and support. And again, for a lot of women, this is really a changing role in terms of sort of the constant caregiving that you've been giving to letting others care for you, and balancing how you feel about that is really important to think through. I'm going to switch gears a little bit and talk through a little bit of just sort of the shared individual decision-making process. So when you're making these decisions, I put this in the order of like surgery, chemotherapy, but it doesn't always have to be in that order, is this idea of shared decision-making. So this is a figure that's actually really more focused on our trainees and our learners and our colleagues. But really, if we think about it, step one, really thinking of, we want your doctor to seek your perspective. So you really need to know what your own values are, what your preferences are. We want to explore and compare the treatment options. So make sure that you ask, like, are there any other treatment options? Are there clinical trials? Assessing what your values and preferences are is very helpful to your doctor. So we know, like, what are the priorities do you have? Do you have travel plans? Do you have plans on, somebody who's, plays piano as a hobby, but is worried about neuropathy? I'm not going to push that, so there's different things that we want to know. And then reaching that decision together is very, very important. So really working with your team to help you understand that your treatment plan and the treatment goals is very important throughout this trajectory. And I cannot state enough that it's important to find a team that you feel comfortable with. So I'm going to take a little bit of a deep dive, because in Ovarian Cancer 101, we really need to get into talking about a little bit about the genetics and the molecular testing. And I want to make sure we cover that, because this is often questions that come up. So terms that we have to understand: cancer genetic testing for a hereditary condition called somatic testing. This is individual gene testing or a panel of genes through a blood test to see if you inherited something that could have predisposed you to developing ovarian cancer. There's tumor genomic testing, which is running a test on the tumor, which could be a biopsy or surgery specimen. And they're testing for all these sorts of changes that may happen in the actual cells of that tumor. So they could be testing for DNA mutations. Something called next generation sequencing, or NGS, is a giant gene panel looking at hundreds and thousands of genes to see if they can create a profile of this tumor, to see if there's anything that would match up in terms of treatment choices. There are many companies that do this, and a lot of internal centers also have their NGS testing. Really, the idea behind this is this idea of precision medicine, which we sort of hear as kind of like a hot topic. But to really understand what that means is that, can we use these molecular testing, such as NGS, to allow each patient to get as much of an individualized therapy based on their specific genetic alterations of their tumor? But again, personalized medicine could really apply to other things, like what are other health issues, other medications, age, patient preferences. So I think this is a way to kind of take something where we're kind of throwing the same treatment at everybody to really try to individualize it for people. So it's really important that we know that all ovarian cancer patients should undergo cancer genetic testing. It's strongly recommended. It's covered by insurance. It's covered by Medicare. And that involves also some genetic counseling. There are new models at looking at online counseling and telephone-based counseling that are also important to think about. This is important for several reasons. First, to determine if there's a hereditary breast and ovarian cancer syndrome or other genetic predisposition syndrome. Number two, share information with families. So this cascade of who could get tested may allow early prevention or early detection of other cancers if we're able to screen from them. In addition, what's really important to know, even in somebody who says, look, I don't have any children, I don't have any siblings, I don't really want to do testing, it doesn't matter to me, it does matter now because genetic testing can actually guide us in our primary treatment decisions about chemotherapy. And that's a really important push. So we're really pushing people to get genetic testing done sooner and sooner. So in general, to back up, when we think about genes that could cause ovarian cancer, about 18% of ovarian cancer will find some kind of genetic predisposition. So most of those are BRCA mutations or BRCA1 or 2, but there can be many other genes that can also have similar function and cause similar issues of early or hereditary cancers. Lynch syndrome is a condition which is more often known for uterine and colon cancer, but also does have a risk of ovarian cancer. So one of the things is the origin of cancer is, familial, hereditary. The gene mutation is inherited in the family. So these are all important to know. When we think of a family tree for somebody who has a sporadic cancer, it's just one isolated person, for example, where the arrow points. When we think of somebody who has a hereditary cancer, we think of multiple generations of patients who may have breast and ovarian cancer, perhaps. So again, cancer genetic counseling, decision-making process, pros and cons is very important. This is a blood test again, and deciding whether or not we're going to do just the BRCA1 and 2 test, depending on your family history, or a larger panel of testing to find other genes. So BRCA genes function as a way normally to suppress tumors from growth, and they encode for proteins that are involved with the DNA repair mechanism. So you can inherit one mutation, one copy of a mutated gene, and that may predispose you to cancer, because if you lose both copies along the way of your life randomly, the cells are unable to use one of the normal ways of repairing this. And because of that, that's why we can also use the PARP in combination. So one of the things that we can kind of think about, I think I went over this a little bit. Sorry about my slides here, but one of the things that we can think about is tumor genomic testing again. And there's also all of these other types of testing that we'll often do on the tumor. So there's the NGS, the next generation sequencing on the DNA profiling of the tumor. There's also something called homologous recombination testing, which really has to do with that DNA repair pathway. So tumors that may be HRD deficient may actually also benefit from the PARP inhibitors as well. And so that's really important to think about. We do know that we have studies that show that women with BRCA mutations and women with HRD deficient tumors may actually have a survival advantage with the utilization of those PARP inhibitors, for example, that we talked about earlier. So again, I'm introducing these concepts so that you have something to kind of think about and talk through with your physician as well. So finally, I think one of the important things when we're thinking about sort of the ovarian cancer continuum is sort of what happens after initial treatment. And obviously this is on the mind of all of us as practitioners and all of you as patients and caregivers. And I think that's what I wanted to spend a little bit of time focusing on, and really acknowledging that there are going to be post-treatment peaks and valleys. One of the things that is obviously we're very happy to be at the end of completion of therapy. So this is an accomplishment for getting through the chemotherapy and surgery and the amount of work that people have to do in terms of their recovery, both physical work, emotional work. And ideally, many of the chemotherapy side effects will start to kind of slowly fade away, although many people will feel like these continue for a long time afterwards. There's a lot of freedom from appointments. There's an ability to return to a more normal schedule. However, this obviously in the time of COVID, we've all had to adjust what our expectations are as well. And that can be also frustrating and challenging for someone who's undergoing a treatment. We do know that in general, after treatment, initially you're probably still considered to be immunocompromised and maybe a little bit more at risk for things like that infection and, comparatively. But when you're off of chemotherapy and your counts are okay, I think we do get some more freedom back in terms of things as well. And so it's important to talk to your doctor about those individual issues, especially in our current climate. But there's also these valleys, worry about cancer, recurrence, surveillance, sudden change, and not seeing our provider team. So not going from seeing us every 3 weeks or every week or talking to somebody every week to suddenly us saying, okay, great, you're doing fantastic, I'll see you back in 3 months, can be really a shock to the system. But we do want to provide reassurance, thinking about how you're going to gain reassurance, and also kind of finding this new normal, which again, I think is really important. And I think patients have taught me over and over again that they do have this adjustment process. And this can be a time to make sure you're checking in with yourself about any issues related to anxiety or depression or just kind of normal coping after a big event that's occurred and really changed the worldview. So I think it's important to kind of allow yourself to understand that it's not going to be just a perfect feeling all the time. Goals after initial treatments really are for surveillance. So we really want to make sure that there's no cancer progression or recurrence. And so we'll often use things such as CA-125 and pelvic exams. And we will often usually do that in every 3 months initially, and then sometimes stretch it out to every 6 months eventually. And also important to think about making sure we're not seeing any other secondary cancers. So after a certain time, if it's appropriate, you'll be making sure your doctor has you up to date with mammograms and colonoscopies, but really assessing sort of medical and psychological late effects is important. And I think it's, really important in ovarian cancers because we do know that we have a higher risk of recurrence from ovarian cancers than we do, for example, from some early breast cancers or some early uterine cancers. But everybody's case is different. And so getting an understanding of what your surveillance plan will be and what treatments you went through as part of your treatment summary plan is a very important element of kind of the survivorship model. So again, we want to prevent new cancers. We want to avoid late effects if we can. We want to intervene. And some of the issues that we may need to intervene about may be this ongoing fatigue, psychosocial distress for both the survivor and the caregiver, sexual dysfunction, and talking about sex again. And some of these concerns may be more financial or maybe more related to other different elements of your life before and your life afterwards. And so I think it's really important to think through those things and to not be afraid to ask your treatment team for those types of resources. So again, I think the survivorship issues are really important. So fertility concerns, obviously this is something that's addressed in the initial treatment, but the consequences of dealing with that type of grief or loss, if you've not been able to or have lost fertility, menopause, whether it was early or more sudden, other illnesses or other chronic conditions such as diabetes or cardiovascular disease. And again, a lot of this is sort of thinking about how do we think about this cancer diagnosis as just one element, but such an important element that we have to adjust everything else around it. So I think, going through that, it's really important. This is one of my favorite slides because I think we really need to focus and keep the center on kind of quality of life. And when we think about this, survivorship exists in the fact that we want you to be physically well, we want you to not have a recurrence, and we want to be able to handle certain things for you if there is a recurrence. We do know that happens. And obviously there are multiple drugs and multiple agents that, I know some of these other, talks will cover that will often sometimes have patients living well and living with cancer for a long time. So physical and well-being is important. Social well-being is important. So thinking about the whole big picture, as well as spiritual well-being and psychological support. So I think if we can kind of focus in on that as part of the background for dealing with a new ovarian cancer, I think that gives us a really good basis to kind of turn to and think about where other where other resources can come from. So that's the end of my talk, and I just wanted to thank everybody for their attention and hope this is helpful, and wish you the best of health, and hope you enjoy the rest of the conference. Thank you.